Here we are. Okay, so I'm going to talk to you about our experience in using MR-guided focused ultrasound in liver tumours, and the title very deliberately says our early experience. And although we've been doing this for a while, it's still early experience. We've done something like 10 cases overall, and I wouldn't claim to have any substantial caseload to give you outcome measurements, but I can tell you the measures we have used to allow us to treat these liver tumours. Now, again, I'm going to, in my first slide, insult your intelligence and tell you what I think the world needs to know about liver tumours. Now, first of all, most liver surgeons would tell you that surgery and transplantation are the gold standard for treatment. But if you look at their figures critically, then this doesn't really stack up terribly well, because only around 20% of all patients with liver tumours, and by that I mean metastases or HCCs, are actually suitable for any form of resection. The results of that resection, the best possible, is around 40% 5-year survival with surgery. That leads us to calculate that around 8% of patients that liver surgeons treat will survive for 5 years. That's no sort of gold standard, is it? Chemotherapy for liver tumours is poor. Now, chemotherapy for liver tumours has improved immensely over the last few years, and therefore, by poor, I mean the previous results were dismal, so now we're up to just poor. A variety of percutaneous ablative techniques have, however, developed over the last 10 years, and these offer a very different way of approaching liver tumours. These allow local treatment for local disease when you have relatively limited disease, and these have changed the way we look at liver tumours in many instances. And the best results for these are around 40% 5-year survival for hepatocellular carcinomas, under 2 centimetres in diameter, and around 35% 5-year survival for metastases, again on the small side. And the interesting thing here is, again, backtracking to the liver surgery gold standard, that 2 studies have been done where patients were randomized to either surgery or ablation in patients with hepatocellular carcinomas of under 2 centimetres diameter. 2 and 3 years on after those interventions, there is no difference. So it would seem that surgery has very little advantage in the treatment of the small hepatocellular carcinoma. That study has not been done in metastases. Okay, so let's move on from the philosophy to the actuality of trying to do focused ultrasound with MR guidance here. Now, the big problem, as you, I'm sure, have heard already from several speakers, is the ribs. Currently, we can't get focused ultrasound across the ribs very easily. In terms of the footprint of the machine that we use, which is the Xablate 2000, the footprint of the array is quite large, and the ribs absorb the energy and destroy the focus, so you really can't get through. The ribs provide a moving, partially impenetrable barrier to ultrasound, so it's very problematic. So we have restricted ourselves to, at the moment, treating patients who either have lesions below the rib line that we can access, or who have masses in the left lobe that are not covered by the ribs, so we can get at them. Now, we hope that the problem of getting at the liver between the ribs will be solved over the next 12 to 18 months or so. Those of you who have heard me lecture before will realize that I've been using the 12 to 18 months time scale for the past 3 years. So I'm having trouble counting. I'm sorry about that. However, the way we anticipate getting over the problem is to build much larger transducers with multiple arrays, and many of these arrays will be able to be switched off in front of the ribs, so you can sonicate between the ribs with banks switched off and still get a effective heating at the focus, much like some of the work Krit Moonen showed earlier on today and yesterday. The other big problem in the liver, of course, is respiration. Respiration voluntarily is very unpredictable, and unless you do something about it, you will never be able to confidently control the 3D space of where you're trying to sonicate. So to overcome that, at the moment we're using general anesthesia, where we link the ventilator and the respiratory excursion to the focused ultrasound machine. So we always return the degree of respiratory excursion to the same level, and we work off that. So therefore we recapture the 3D spatial control. The difficulty with that particular approach is that the anaesthetist does not control the ventilation for much of the time, which, as you can imagine, is a very popular way to go on. They love it. Okay, let me show you some cases that we've done using that particular paradigm. So the first one is a 54-year-old woman who has hepatitis B, and she has cirrhosis associated with that. She's a Nigerian. She initially had a 6-centimeter hepatocellular carcinoma, which we initially treated with MR-guided laser ablation. That's also an area that we do, and she'd also had hepatic embolization for that. She now presents with a 1.5-centimeter new hepatocellular carcinoma with marked neoangiogenesis in segment 3. And I think I've got these two sides the wrong way around, but you can just about see, whoops, I didn't mean to do that. You can just about see the lesion here on this unenhanced one. There it is on the sagittal. And I've got the slides slightly out of order, so let me just go forward and I'll come back to that one. There is the new area of neoangiogenesis. There is the previous area that we have successfully treated. So she's got a new small hepatocellular carcinoma, very anteriorly in the left lobe, not covered by the ribs, which we can therefore access relatively easily. And here is, oh dear, here is the thermal map that we achieved during that study. The blue stuff is the area that's been treated and had its temperature raised to 55 degrees centigrade and over for more than 1 second, and the green and red portion are the ones that we've just done. And we know that this is going to be an easy thing to do because there is so much experience in laser or RF ablation of the liver, so we know that the liver responds well to heat. We know that we can do thermal mapping in the liver relatively easily. So you know that once you can get at the liver and deposit focused ultrasound energy there, you will be able to do effective treatments. And this is the sort of treatment we achieved in this case. And here you can see a subtracted post-contrast image showing you the decreased perfusion of that area, which is encompassing the hepatocellular carcinoma we treated. Here's the patient in follow-up, and there you can see that brightness on T2 weighted images, which represents hemoglobin degradation products slowly decreasing. Here's another very good example. This is a 72-year-old gentleman from the Middle East with known hepatitis C on this occasion, and he has a very cirrhotic liver and a rising AFP. Was noted to have a 3-centimeter mass at the anterior aspect of the left lobe of the liver, and he wanted some definitive treatment. So here's a CT, which is very unusual for me to show a CT, but there is a CT because this is what he came with, and there is the mass there. His ribs are quite close, so we can get at the mass, but probably not its entirety because the ribs are close. This is diffusion-weighted imaging, which we're finding very useful for all our hepatocellular carcinomas, and you can obviously see a large area of diffusion restriction there, and here's the ADC map confirming that that is diffusion restriction. And post-contrast images, he breathed and moved, but there isn't much neoangiogenesis in this tumor, suggesting that it's a relatively well-differentiated hepatocellular carcinoma. Here's a coronal image showing you exactly where it is. There it is, and there you can see the rib cage, and it looks pretty good here, but in fact, slightly further forward on the next slice, there were further ribs along this lateral margin of that small tumor, which partially obscured it. Thermal maps are easy to produce in the liver. You can see we've put multiple fiducial markers here to make sure that we're always in the same place and that we know about it. And there are the lesions we're producing right across the full depth of this tumour. And here's the temperature readouts again, and you can see we're getting quite substantial temperatures relatively easily in this area. And this is a thermal map in the sagittal plane, as you can see here. This is sagittally, and we're getting, again, an oblique thermal dose across this mass. This is diffusion post-image, and you can see what a change there has been in diffusion almost immediately. Diffusion works fantastically well, very rapidly in this context. But when you do the post-contrast images, you get a much more better spatial resolution, and you can actually see what's happened. So there is the area that we have destroyed, but you can see that we haven't been able to destroy the lateral and inferior margin because they are obscured by the ribs. And this is probably even more clearly visible. There you've got the transducer angled to the correct obliquity, and this is post-treatment, and there is the residual area of malignancy along there, and that is the portion that we have effectively treated. Okay? So we couldn't get to all of that with our focused ultrasound setup as it is at the moment. This is just a subtraction image, just showing you rather more clearly what we've done there. So the initial results of the work we've done so far are quite encouraging. We can do it. It's easy to do with the general anesthesia. We can produce ablative lesions easily in the liver. We know that from the extensive, if rather idiosyncratic work that's been done elsewhere, that liver lesions respond well to focused ultrasound. You know that percutaneous thermal ablation procedures have become widespread very rapidly in the liver because this is an area where conventional therapy is lacking. It's highly problematic. For hepatocellular carcinoma, virtually everyone has severe liver disease. And in my personal opinion, despite what Neil Cassell says about the brain, which obviously is a very elegant application, for me, this is the biggest application you can see. Patients are seen in every single hospital in the world every day with hepatic metastases which can't be treated. Focused ultrasound could have a huge role in this area. But obviously there's a lot of technology development to achieve this, and it will be very challenging, but it's something we must take up. And once you can reach all the areas of the liver, the other abdominal organs are also immediately treatable. So for me, this is the most important application of direct thermal destruction of tissues, since the problem of hepatic secondaries and hepatic primaries is so prevalent and so difficult to treat. The potential you have is for a hepatic ablation. The patient just walks in, lies down, has the ablation, and walks out. If you have chronic liver disease with severe problems, that is a massive change in the way you treat patients with liver disease, an immense paradigm shift. So we hope that the prototypes will get to most of the liver very soon. You see, by the end of this lecture, I've called it 12 months rather than 18, and perhaps the combination of local drug therapy will take us even further in this field. Thank you very much.
Thank you, Roddy. So if you give this lecture 2 more times, you'll be there.
I'm not sure about that.
Are there any questions?
The question was, for those of you who can't hear, have we damaged any ribs? And we haven't damaged any ribs, but it is very possible to damage the ribs, and I know of other cases with other systems where people have done precisely that. Someone over there.
Hello. For patients' eligibility for the treatment for liver besides the ribs, what other obstacles could be for them to be considered for treatment? Is that the main obstacle? Just ribs?
At the moment, the only obstacle we have is, can we get at the lesion, which is predominantly the ribs, and are they medically fit for a general anesthetic?
Okay.
Outside of that, if they meet those 2 criteria, they're in.
Okay, excellent.
there are no more questions, we'll move on. Thank you very much, Roddy.